Hello, everyone, and welcome in. It's great to see you all, and yes, Happy New Year, Year of the Rabbit. I enjoyed Chinese New Year on the weekend. It's great to have everybody here along for the webinar tonight. I'll be presenting along with Grace. So Grace and I both come with experience and passion for the area. I am passionate about sepsis. Grace is passionate about paediatrics, so hopefully that means you get the best of both worlds. We're really excited to bring a multidisciplinary webinar to you on paediatric sepsis, courts in session, and really focusing on that, calling for expert help early. Just a little bit of housekeeping. We have got all of your microphones turned off, but please, as you are, just put all of your comments into the chat box. We've got a really big audience tonight, and we may have some people that are watching from YouTube, so welcome if you're in the YouTube world. We will be putting some posts in just with some links into the chat box that you can access. I would like to acknowledge our country. So we acknowledge both the Australian Aboriginal and Torres Strait Islander peoples as the first inhabitants of the nation and the traditional custodians of the lands that we live, learn and work. I'm presenting from Meanjin land tonight, which is home of the Turrbal and the Jagera nations. At Medcast, we pay our respects to the elders past and present and extend that respect to any First Nations people who are present tonight. Next slide. Thanks, Grace. So yeah, just make sure that you change your chat down to everyone if you've got any comments, but if you've got any concerns or technical issues, that can just go directly to us as hosts and panelists. So to begin with tonight, we just really wanted to express, I guess, some lessons or some important sort of points to note around what we're doing. So we are focusing on a coroner's case, and the idea around looking at coroner's investigations is really to make sure that we are learning sort of the lessons from these misadventures. It's really easy for us as clinicians to look at a situation in isolation and to be able to easily see what should have been done. However, when we consider all of the demands that can be placed on us and how we reach our decisions, we've probably all been in a situation where we haven't always made the best decision or the decision that we would have made in hindsight. So during this webinar, we will be exploring a coronial investigation, and it's actually of a case that occurred quite a while ago in 2013, but the report from the coroner was only published in 2020. And this is sometimes the case with coronial investigations because they want to gather a lot of data and evidence. They're allowing often the healthcare facilities to put changes into practice. So while we're exploring the issues of the case, we should be mindful that there may be people that are present here tonight that may actually have been involved in the case that we'll be discussing. And certainly the points that we'll be making and the questions that we'll be raising are never in criticism of what was conducted by the people that were involved. It's also important to remember that you may have been present in something similar to this. It may not always have ended up in a coroner's court, but any of us that have been involved in a case where we've had to do a HEAPS investigation or root cause analysis, you'll know the amount of sort of stress that can place on us as healthcare workers. So just a reminder, I guess, to be mindful of that in the chat box if you are putting comments in, but just to also be aware of yourself and make sure that you are checking in with yourself. So if this does sort of, tap into any issues that you may have had from past events or any areas of concern, please reach out either to us at Medcast or to your sort of fellow colleagues and support network. One of the reasons why we are focusing on this particular case is because we want to really emphasise that importance of our 8th standard, which is around that recognition and response to acute deterioration, and sepsis really fits into that. So our sort of target or our goal, I guess, is clinicians, and it doesn't matter where we're working, whether it's in primary care, acute care, sort of critical care, we all have that obligation of making sure that we are adhering to the standards and that we've got some systems in place that help us to recognise when we do have a deteriorating patient, but also around escalation. So escalation is really important, and you'll see how that played a role in this coroner's case, and how the role of the family is very important with paediatrics. So with that, I'll hand over to Grace, who's going to do the bulk of the presentation tonight, and she'll take you through the case. So thanks, Grace.
Thank you, Susie. Okay, so I'm presenting from Taungurung country, so that's out near Heathcote in Victoria. So thanks so much for acknowledging country, Susie. So I want to actually kick off with asking a question. So we're going to do a bit of a poll, so you can vote. This will come up on your screen in a moment. You've got a 2-year-old First Nations child who's presented to an emergency department, or it could be a primary health service. She's got a temperature of 38.5 and a heart rate of 120, crying and unsettled with symptoms of an ERTI. What are your initial thoughts? Has this child got sepsis? And this is a common presentation for children. You know, viral illnesses are one of their most common presentations to ED. So, you know, often this will be how they first sort of arrive. So give people just a few seconds to answer. And we can see that the majority of you guys are thinking yes. Straight off the bat, there's some red flags there for you to think that we might need to consider sepsis in this presentation. So I just wanted to start off with a bit of a recap around normal pediatric physiological parameters. So for some of you, you may work around children all the time, and this is something that you're really familiar with, which is great. But if you're just sort of seeing children every now and then in your practice, you might not be as familiar with these parameters. So just to remember that with kids, when they're younger in particular, you know, in that sort of, just trying to get this out of the way, when we've got them at that birth age, they have quite a variable respiratory rate. So anywhere up to 60 can be normal, but we want to see that sort of vary. So it would come back down to 40 at rest. Then once we consider them an infant, which is past that newborn phase, we would expect a respiratory rate between 20 and 30. And that carries on until we get to adolescence, where it's more like what we'd expect for an adult respiratory rate. Likewise, with our cardiovascular rates, when we're looking at a newborn baby, their heart rate is a lot higher. Children don't have, at younger ages, so under the age of 7 in particular, they don't have that ability to vary their stroke volume to increase their cardiac output. So their hearts tend to go a lot faster, and tachycardia tends to be something that comes on a lot quicker when they're unwell. And again, as they grow, we see their heart grow as well. So therefore it becomes a lot slower. The systolic blood pressure is 70 at birth, 70 to 90 as an infant, which goes all the way up to 1 year of age. And again, that starts to reduce down to adult, what we would expect in an adult as you get into adolescence or over the age of 12. Another thing that I wanted to highlight before we continued on was just a couple of different assessment approaches for pediatrics. The first one, if you haven't been made aware of it before, is the Paediatric Assessment Tool, which is the PAT tool. And the reason why this is really useful is it's basically an assessment you can do on children without having to touch them at all. So it's purely observational. And as you're probably aware, developmentally normal children are going to be scared of strangers. And as healthcare professionals, we would definitely be strangers. So approaching them might instigate distress, which can obviously make their physiological parameters become elevated and maybe not what we would expect. So just quickly having a look at their appearance, we're looking at things such as their tone, their interactiveness, so particularly with their caregiver, like whether they're meeting their gaze, also around consolability. So if they're really unsettled, how easily and quickly is their caregiver able to settle them with normal comfort measures. If they're able to verbalize, and we would also look at their speech. When we look at their work of breathing, we're looking at all of those things like their breath sounds. So can we hear stridor? Can we hear wheeze? Their position, are they in a tripod position? Retractions, nasal flaring, grunting. And then when we're looking at circulation, we're looking at their pallor and their color, signs of mottling or signs of cyanosis. And just below the triangle, you can see how we then use that information. So if any of those areas on the triangle come up as red flags for you, you would highlight that part of the triangle, and that obviously would highlight that area. So for example, work breathing would indicate that they are at high risk of respiratory distress. However, if you've got multiple areas of the triangle that are highlighted, so for example, if you've got the circulation area plus the appearance area with red flags, this is going to give you a high suspicion of them having shock. So really super quick and easy tool that you can use as a child comes in to sort of ascertain whether you need to get expert help right now or not, without even needing to touch them and do, you know, more invasive observations. But obviously we do need to do more invasive observations. And when we approach this, we should do this in an A, B, C, D, E way so that we make sure that we don't miss anything out. So obviously looking at our airway, making sure that that's patent, breathing. If we haven't already had a listen to their chest, I usually would leave anything that involves touching the child right to the end, because obviously if we go in there and upset them, it might send everything else out of whack again. So if I'm going to have a listen to their chest, I usually couple that with, you know, taking their temperature, doing a blood pressure, doing a capillary refill and all those sort of things. And in circulation, it is, you know, trying to get a blood pressure, which I know can be really challenging in kids, but we really should have one at least once per shift on a child. For disability, we're looking at, you know, the AVPU score. Are they awake? Are they only responding to voice, pain, or are they unresponsive? But we're also looking at if they've had any history of seizure activity, or potentially taking a blood glucose if we think that we need to. And then for E, this is exposure. So this is things such as their temperature, but it's also exposure of their body. So can we see any evidence of a rash or any mottling? What's their color like? And all of this should be documented really well in your patient assessment also. And so just to spend a little bit longer on cardiovascular and just sort of go into that in a little bit more depth than the above. When we're looking at that cardiovascular assessment, we often think about, you know, blood pressure. But as I said, and you probably are aware that getting a blood pressure, an accurate blood pressure on a child can be really difficult. So if you are struggling to get an accurate blood pressure, and I don't want to discourage you from trying, because it is really important that we do get these, but also try and get these other little bits of information as well to inform you about their cardiovascular assessment. So doing a capillary refill time, having a look at their ECG to see if there's any abnormalities, touching their pulse, so touching it both centrally and peripherally and feeling what the strength of that pulse is. You know, is it weak? Is it bounding? Does it feel normal? And also getting a good idea of what their urine output has been. So getting that history from their parents or carers, or beginning to measure that in some sort of way, or if they've had a wet nappy, taking a look at the urine, does it look really concentrated? You know, bits of information like that. So, you know, looking at that cardiovascular assessment holistically. And just to play quickly for you a video on how to perform a capillary refill time, because the other thing that we notoriously do is not spend long enough on this. So just to reinforce that when we're doing capillary refill time, we need to push down for at least 5 seconds, and then we want to measure the return of the circulation following that. So 1, 2, that would be a capillary refill time of under 2. Okay, so let's get into our case study and our coroner's case study for tonight. We're looking at Tiana, and this name has been changed in the interest of protecting the identity of the coroner's case, but these are accessible to anybody in the public, so you could easily find this one. So Tiana is a child of 2 years and 10 months. She's had a 1-day history of a febrile illness. She's presented to ED at midnight following a disturbed sleep. So her mum's brought her in because she's just been really unsettled. She's got a temperature of 38.5. So she's been treated in the ED with some Panadol, and they've given her an ice block. The medical staff have reviewed her, and they've diagnosed her with an upper respiratory tract infection. We can see in the coroner's report some observations from that initial presentation. We can see that her airway was patent, but we don't have any information on what her breathing was like, what the respiratory rate was at this point. Any cardiovascular assessment isn't in the coroner's report. Doesn't necessarily mean that it wasn't performed, but we don't have that information. We can see that she was alert, and we obviously have the information regarding her temperature. So look, this might mean that these observations weren't performed, or it could just mean that it wasn't deemed important to add into the coroner's report at this stage. So we're not exactly sure why they're not there. So before we take a look any more at this case study, I want to have a bit of a look at, how sepsis evolves. So looking at this initial presentation of this child, I asked, with our first poll, would you be prompted to think that this child had sepsis? And over 80% of you said yes, it would already be on my radar that I need to be thinking about sepsis. And maybe that's because you've come to a sepsis webinar and you've got a bit of a hint that maybe that's what we're talking about. But let's have a little bit of a look at how sepsis evolves and what's happening in the body. So sepsis and septic shock are actually responsible for around 10 to 25% of our paediatric intensive care admissions worldwide. As many as 30 to 50% of patients will come in from other hospital wards, whereas the rest are admitted directly from emergency departments and into paediatric intensive care units. Usually children with chronic health conditions have a higher risk factor in having sepsis. And 77% of patients that end up in a PICU have at least one comorbidity. Sepsis can occur as a result of an infection at any body site. So this can include the lungs, the abdomen, the urinary tract, skin, soft tissue, or it can be the result of a primary bloodstream infection. Bacteria is usually the pathogen which is most commonly associated with sepsis, but fungus, viruses, and parasites can also cause sepsis. Basically, the pathogen triggers the production of our pro-inflammatory cytokines and our tissue necrotizing factor and our interleukins, which then all trigger more toxic downstream mediators to mount that defense against the pathogen. Sepsis occurs when these factors begin to exceed the response which is required for the pathogen and actually begin to overwhelm the body. So sepsis can be difficult to identify, but it's usually denoted by very high or very low body temperature, high heart rates, high respiratory rates, and high or low white blood cell count or a known or suspected infection. So the mediators which have been released into the body, once we've got that overwhelming response, they start to damage our endothelial lining and they promote increased capillary leakage. So furthermore, our cytokines then lead to the production of adhesion molecules onto our endothelial cells and our neutrophils, which in turn promote further endothelial injury. So it just exacerbates and builds. Then our activated neutrophils additionally release nitric oxide, and this is a patent vasodilator. So then this then leads on to hypotension, and then we start to see that acute organ dysfunction. The acute organ dysfunction is categorized by our symptoms such as our decreased urine output, our changes in mental status. We might also see things like decreased blood platelet count, difficulty breathing, the abnormal heart function, reduced cardiac output. Children might also complain of severe abdominal pain. And this is why urine output obviously is a really important factor that we measure because it's going to help us identify, this organ dysfunction and also help us track the progression of the sepsis. Another really important thing that I want to mention here is that hypotension in children, sepsis or anything else, is a preterminal sign. So any child that you've got who is hypotensive, get ready to resus, because if we don't get that blood pressure up as soon as possible, they will basically need to be resuscitated. So hypotension is always a preterminal sign in children. And if we get a child with sepsis who's hypotensive, then they're going to have a higher morbidity rate. Okay, so how do we identify sepsis? We've talked about now how bad it is, that we don't want it to happen, that we want to intervene earlier. So how do we know if a child who's presenting has sepsis for sure? Well, there was a really good study which was released, and I'll get Susie to put the link to the study into the chat so you can access that if you like to geek out on journal articles like me. And this was called Identification of Sepsis in Paediatric Emergency Departments, a Scoping Review. And I've put here what the common ways people measure for sepsis and pediatrics in emergency departments. And as you can see there are quite a lot of different things that people are looking at in different areas to tell them whether the child that they're seeing has sepsis. So there's significant heterogeneity in the different reference standards that we use for defining sepsis and when reporting whether we're managing to identify sepsis. So we really do need a clear agreed upon definition of sepsis so that we can reduce this and be able to collectively analyze, how we're doing as well. So it makes it hard for us to track how we're going treating sepsis when we're measuring it in so many different ways. This has certainly been an ongoing challenge, and there's ongoing international consensus to try and reach agreements. I want to just pull out a few of the key studies from this meta-analysis. So it identified 89 different studies, which all reported different outcomes of different prediction, detection, or diagnostic tools for sepsis or severe bacterial infections, all the way from 1990 to 2022. So one of them, which was Lee et al. In 2019, reported that most clinical markers, except for pre-existing clinical problems, were associated with false positive sepsis screens. Then we had Mitengi et al. In 2018, who reported that the association of negative symptoms, such as a lack of a fever, was higher with invasive bacterial infections. And then we've also got a study which was done in the setting of a pediatric intensive care unit, so not in a ED. And what they found, which was Weiss et al., was that there was discrepancy even within their unit between the definitions that their researchers were using to define sepsis, the definitions that clinicians were using to say this child has sepsis, and then also the administrative codes. So the IDC codes that they use to bill and categorize within hospital, that definition was different as well. So we can see why there's a lot of confusion around recognition of sepsis in children, because we don't have there's a lot of confusion around the way that we all define it, even within our own departments. So I have tried to make it easy. Looking at all the different protocols and procedures and information that's out there, we can see that there's a few key themes that most of them have in common. And there was an International Paediatric Consensus Conference in 2005, which said that there should be at least 2 of the following 4 criteria. So the child should have a temperature which is either above 38.5 degrees or below 36 degrees. They should have tachycardia. They should have increased respiratory rate, and they should have an abnormal leukocyte count in the presence of suspected or proven infection. The other things that are commonly referred to in the literature or in different protocols are also the abnormal mental state and reduced cardiac output. And if we go further than leukocyte count, and we also talk about lactate, that's another blood marker which is often commonly referred to when we're looking at diagnosing sepsis more definitively. And just last year, I was teaching PALS out in a rural location, and I had some of the participants say to me, nearly every kid who walks through the door with a viral illness would initially look like they had sepsis because they're tachycardic, they're irritable, they look unwell, but they haven't been given any Panadol at home, and sometimes they might just need that, and then everything settles and is fine. So I think what we really need to do is we need to look at that whole picture, and we need to be looking at, is there a suspected or proven infection? Is there a temperature, or is there a, hypothermia? Is there elevated heart rate and respiratory rate and altered mental state? Is there reduced cardiac output? And then do we want to then do an invasive test or a finger prick to then look at lactate or leukocyte count? So again, coming back to that really thorough assessment, really thorough ABCDE assessment, particularly that focusing in on that really good cardiovascular assessment, it's going to bring up those red flags. If they've got delayed capillary refill, if they're hypotensive, then we know that, sepsis is on our radar. We should initiate our sepsis pathways. Obviously, petechial rash is another one which we are well educated in as being, of concern for meningococcal meningitis. So that, again, would pick up on an ABCDE assessment with our exposure. It is complicated because there's lots of differing diagnosis, but we can simplify it as well. So I also just wanted to touch on some of the assessment tools that are out there for defining sepsis, or that you might have come across. In adults, they've got the sequential organ failure assessment, which is called the QSOFA. And this is a score which is proposed as a screening tool for clinicians outside the ICU to promptly identify patients who have infection, who are more likely to have poorer outcomes. So there was actually a pediatric version of this tool developed. It's called the Liverpool QSOFA, or the LQSOFA. And basically, you can see in this table here, if you've got a delayed capillary refill time, you get a point. If you're only responding to voice, pain, or you're unresponsive, you get a point. If your heart rate's above the 99th percentile for what would be acceptable for your age, then you get a point, and likewise with your respiratory rate. And if you get more than 2 points, this is associated with poorer outcomes. So this is different to the adult QSOFA because they include blood pressure, whereas as I identified earlier, when we're looking at hypotension with children, you're already increased mortality rate with them. They're already too far. So we don't want to be looking at that as an early predictor. That's a late, terminal sign for children. So I have a link to this journal article as well, which we'll get Susie to pop in the chat. And if you're interested in having a look at that article in a bit more depth, you can access that through PubMed. Okay, so time to ask you a question again. So we've got a 2-year-old child who's presented to ED. They've got an elevated temperature and they've got tachycardia. They're crying and they're unsettled, and their symptoms are consistent with an upper respiratory tract infection. The temperature has not reduced with Panadol. So what would you do? At this stage, would you give them a bit of Nurofen now to see if their temp comes down with that and just observe for a few more hours? Would you go, yep, let's chuck in an IV, let's take some bloods, let's start IV antibiotics? Or would you administer Nurofen, send them home, let them know how to keep the temperature down, say keep up the regular Panadol, and actively cool that temperature? Okay. All right, so we can see here that we have almost a 50-50 split there. Some of you will give a bit of Nurofen and observe for a few hours, and some are going to insert the IV, take blood cultures, and commence IV antibiotics. And I think both of those answers, and the fact that we don't have a lot of information other than this case study would be okay. Unfortunately, in the case of this coronial investigation that we're looking at, this child was sent home with some Nurofen and with instructions to bring down the temperature. So it's difficult, again, to know in the context of the different demands that might have been happening at the time, but obviously to acknowledge that temperatures are a normal part of our infection process, and that we've got research and we've got data to support the fact that we don't want to be actively cooling temperatures just for the sake of bringing them down to normothermia. So we'll be treating the child, not treating the temperature. So if that child's really unsettled and unstable with their temperature, then of course we would administer Panadol, potentially administer Nurofen. But in doing that, we do then have the risk that we mask more of the symptoms of sepsis. So really we want to be administering Panadol and Nurofen if the child's really distressed with that temperature, or if they're not coping with the temperature from a physiological point of view. Obviously, having more thorough assessment is always going to help us again. So if we do decide to give them a bit of Nurofen, watch them for a bit longer, continue to monitor them to see how they respond to that, to see, if they have any more red flags or if any more causes for concern pop up. So that brings us to our first event, essentially. Tiana got sent home, and when she was at home, she was settled for short periods of time. But at 10:30 the next morning, her temperature shot up again to 38.9, despite the fact that she'd been receiving 4-hourly Panadol and cooling measures at home as instructed. She was now starting to have some difficulty breathing, and so her mother administered her a dose of Ventolin and then returned with her to the ED. We've got some information around her patient assessment at that point in time. We can see that her airway was patent, her respiratory rate was 44, her SATs were 97. We don't know what her cardiovascular status was or her disability status. And we know that her temperature by the time she got into ED had actually come down to 37.3. So now knowing this information about her, this is her second presentation at the ED. So I want to hear again from you. We've got a 2-year-old child who's represented with the ED, to the ED with ongoing temperatures. She's got an elevated respiratory rate of 44. So we know that for her age range, this was elevated. And we know that we've had to administer her, or her mum's had to administer her Ventolin for difficulty breathing. So if we launch that poll, and then everyone can have a vote on what they would do for the second presentation. So we can take further observations, try and get a blood pressure and capillary refill time, or we can determine at this point that we have a child who is likely experiencing sepsis, and we can initiate the sepsis protocol, pop in an IV and commence antibiotics. Or we can have a look over her and give mum some more support and then discharge her home. Okay, so we've got bringing her in for a bit more observation, or we've got initiating the sepsis protocol. And look, I think we've got enough information at this point to initiate our sepsis 6, and I'm going to talk through why that is the case. But even if you weren't confident with that, I'm happy that nobody's decided to discharge her home, and you're going to bring her in and observe her a little bit more closely anyway. Unfortunately, Tiana did get discharged home at this point. Mum was sent home with a few more instructions. So I think this really highlights to us why early warning tools and our track and trigger tools are so important to flag when we've got children who are, transgressing criteria. So if you're not confident with children, you don't know their physiological parameters, our track and trigger tools are going to assist in flagging that we need to get expert help. We need to refer on to a senior clinician to have them review this child because they are not right. So these have been rolled out across Australia now. They're even making it into hospital in the home. So they're quite well known. There's obviously different ones depending on what state you're in. We've got the between the flags slippery slope here, which highlights how if you intervene at the correct periods of time, we prevent them from getting to that point where we're going to have to resuscitate them. And then we've got the parrot, which is the WA track and trigger tool, which is incorporating a lot more awareness around our Indigenous populations, which is obviously very important because they pose a higher risk of sepsis, and they've also got a higher morbidity and mortality rate. So we really do need to encompass them in our assessments a lot better. So the Australian Commission on Safety and Quality in Healthcare, they include a lot of publications and resources around these tools in line with our Standard 8, recognising and responding to acute deterioration. So I'm going to hand over to Susie now for a little bit, who's going to talk a little bit further on differentials of sepsis diagnosis in the primary care environment.
Thanks, Grace. So look, one of the things that we always need to be aware of is not everybody that has got an infection has got sepsis. So these are 3 sort of examples. So an infant presents with restlessness, tachycardia and tachypneic, history of diarrhea. So does this child have sepsis, or does she have simple gastro? A teenage patient presenting with burning on urination, shortness of breath and complaining of palpitations. Does she have a UTI and urosepsis, or does she have a simple UTI because she's had a sexual encounter and she's actually having palpitations because she's nervous about that or nervous of her parents finding out? A child presents with small red inflammation from a garden scratch. They're slightly disengaged and lethargic, but otherwise asymptomatic. So it can be really difficult with these 3 cases as just some examples of identifying, do any of these patients have sepsis, or do in fact all of these patients have sepsis? So it's not always easy to actually make that diagnosis. So can we test for sepsis? And George, I'll just get you to do the next poll. And so this is around, if you were presented with one of these cases, which of the following blood tests would you consider ordering, or would you expect to be ordered? We've got some spread of the answers there. So I know some of you were probably still answering. Quite a few of you are wanting to do lactate, and that's great. And I'll come back to lactate in a sec. And then some of you have also indicated doing C-reactive protein or procalcitonin. And not too many of you wouldn't do any blood tests. So one of the things that we really have to be considering when we're talking about blood tests is what is the point of doing it? So what are we hoping to get out of the blood test? Now, lactate is fairly useful when we talk about sepsis. And what it does is it really helps to recognise those patients who have got some signs of shock. So it can identify sometimes earlier than what our patients clinically present. So doing a lactate level can be helpful. It's also one of our point of care tests that we can do. So even in some of our rural and remote settings, we might be able to do a lactate if we've got our iStat machine. So you don't need to do a formal arterial blood gas. It can be a venous sample that we can put through an iStat machine. There's also point of care testing like glucometers. And so that may be something that we start to see sort of out there a little bit more on the market when we're talking about lactate and how that can be useful for sepsis. Our other tests that we sort of talked about are less useful. So procalcitonin and our CRP or C-reactive protein are often done with patients with infection, and they're really not specific enough. So what they can do is help to identify, do our patients have infection that is viral related or bacterial related? So they are beneficial to be taking, but they're only beneficial to actually be guiding our antibiotic therapy. So that's where we should be using them to guide that therapy rather than using them to help diagnose sepsis. So there is no one sort of tool to diagnose sepsis from a blood test. Lactate is probably our most useful. How do we triage in sort of that primary care and even in that ED setting? So these are the guidelines from the NICE group, so the NIC from England, and they have a range of recommendations which is around that risk stratification. So the one that you've got up on the screen is for children under 5 years of age. And Grace, I'll just get you to click through. There's a 5 to 11 one, and then 11 to 17 years of age, and then 18 years of age. And Grace, if you can just pop that link into the chat as well. The key with all of those guidelines is really around asking that question, could it be sepsis? So that should be the first question that we ask. So any patient who presents with a sign of infection or a risk for infection, even if they don't have a high temperature. We should also be aware that for some people with sepsis, they may have fairly non-specific or non-localized presentations. So that might be things like that they're just feeling generally unwell. They might not have any other symptoms. They may have unexplained pain or lethargy. So these should all be warnings for us. It's also really important to pay particular attention to the concerns of the parents or caregivers, and then consider any red flags for patients, parents, or caregivers who aren't able to give a good history. So these might be our non-verbal ASD patients, or it may be patients or carers that are English as a second language. So for these patients, we may not get a good sort of picture. And one of the things that we should also be considering is when patients represent. So where was it that they presented to earlier, and what information do we have from that earlier presentation? So a lot of communication can actually be lost because patients have presented to a different facility, so a different doctor, a different hospital. They may have sort of contacted telehealth, and we don't always get that handover. So we need to try to get a good history where able. If you are performing an assessment of a patient remotely via telehealth, then really pay close attention to factors that can increase the risk of sepsis. So that's things like patients that have got an immunocompromised sort of status, whether it's disease-related or medication treatment-related. Know what their immunisation history is and what their current immunisation status is, and if they've been exposed to anything. And then always consider sort of the ethnicity and cultural aspect for patients. So particularly our First Nations, we know that they are at a much greater risk of experiencing sepsis and unfortunately experiencing higher mortality from sepsis. If there is any risk of neutropenic sepsis, then the patient should be immediately referred to secondary or tertiary care. So that's a really important flag. Anytime that sepsis is suspected, then it's important to make sure that you are doing a structured set of observations to assess the patients, including those parental concerns. So the slide that's up there, which is really a repeat of the things that Grace has been identifying for us, is really what we should be targeting. So making sure that we are doing a set of vital signs, paying really close attention to heart rate, respiratory rate, and their refill time, doing that physical examination, so looking at their skin colour, how warm or cool it is, are the presence of any rashes, assessing their mental status, and this may be as simple as then less engaged with their parents, all the way down to sort of patients who are less responsive or obtunded. And finally, just consider whether or not it's worth doing those point of care tests and what you're going to do with those results. So I'll hand you back to Grace now for the next part of the coroners. Thanks, Grace.
Thank you, Susie. Okay, so let's have a look back now at what the next event was. So we have Tiana's mother calling the hospital at 7 a.m. the next morning. She is worried because now her child's temperature is 40.3. She speaks to a nurse on the phone for about 3 minutes and tells her that Tiana's breathing is fast and shallow. And she then has to hang up because Tiana is becoming distressed. So let's imagine that you are the clinician on the phone to Tiana's mum. What would be your reaction to this? I'm just going to launch a poll and I'll get you to vote on what your next steps would be. So your options are to wait for her to call back when she's ready. Maybe, things have just got it out of hand and, Tiana's a bit distressed and she'll call back when she needs. You can try and call her back as soon as possible and instruct her to call an ambulance if she hasn't already, or you can go ahead and call the ambulance yourself and send it to her house. So I'm not sure if that poll's coming up. I'm having a bit of issues with seeing things on my screen. Okay, there we go. Okay. So we'll just end that off now. And so, a few people, well, 39% are going to try and call her back and see if they can get her back on the phone, get her to call an ambulance if she hasn't already. And a few will just call 000 and send the ambulance to her house. So I think it's great to identify that we are, if we hadn't already, which obviously in the case of this coroner's report, they hadn't already identified that this child is very sick. This is certainly a major point in which we need to see that we've got a child who's in crisis here. And again, in hindsight, it's very easy when we look at this information all put together that we know what we would do, but we don't know what the different priorities were on the day. We don't know what the distractions were. Unfortunately, at 1 p.m. That day, Tiana stopped breathing and became unresponsive. So her parents commenced CPR at home and she was transported into hospital with CPR in progress, and she was unable to be revived. So hence why we're looking at a coroner's report. So again, in hindsight, we can see at what points care could have been escalated for this child and where she might have had a different outcome. And I'm going to go on and discuss what some of the recommendations from the coroner's report were a little bit further on. But before I do that, I wanted to have a look at talk about, sentinel events that occur in emergency departments. Safer Care Victoria had a look at all the sentinel events that occurred in emergency departments across Victoria and pulled out the common themes, from those inquests to identify, how they happened or where we could do things differently. And there were 5 sort of key themes that happened, across the board. The first one was parents and carers were experiencing difficulties in being heard. And when they expressed how worried they were about their child and there was a lack of a clear system for how they could escalate that, within that healthcare environment. This next one was limited staff knowledge on the signs and symptoms of paediatric sepsis. So this looked at sentinel events in emergency departments, across the board, but this was one of the key things, which was around sepsis. So that's quite interesting. So this contributed to insufficient monitoring, insufficient investigation, and then we had missed or delayed diagnosis. Then there was the lack of availability or clinician awareness of standardized pediatric pathways, policies, or procedures within the health service to then support that escalation of care. There was delay in escalation to senior clinicians or external services, so specialist pediatric services, to help inform clinical decision-making for acutely unwell children. And then there were children who were becoming critically ill after being discharged home from ED, who were still displaying abnormal Victor criteria or abnormal physiological parameters following a brief observation period. So we can see how nearly all of these points were actually ones that we can consider in Tiana's case as being contributors to why she may have passed away. So if we do have a child who we suspect sepsis on, we would initiate the sepsis 6. So let's now move from looking at how we identify it to saying, yes, we actually think this is what we're dealing with. So what are we going to do about it? So with the sepsis 6, we're looking at 6 key points. So we're looking at firstly involving our senior clinicians early. So whether that is your senior doctor or whether that's a pediatric referral or retrieval service. Then we're going to give them oxygen to maintain normal oxygenation. So that's above 94%. The reason why we don't just give oxygen as a standard blanket rule is because we're trying to prevent adverse effects such as lung injury or microcirculatory vasoconstriction, which is associated with the hyperoxia and the free radical generation. So if they're maintaining normal oxygenation, we wouldn't necessarily place oxygen on them. Next, we obtain access. So in a shutdown or shocked child, it's going to be really difficult to place an IV. There are some really fantastic clinicians out there who are awesome at doing that, but the majority of the time it's really difficult on children to do that once they're in that state. So don't spend too long trying to get IV access. Go for IO as soon as possible once you identify that it's going to be difficult to get IV access. And we need to give antibiotics through that access. It needs to be done within 1 hour of us identifying that we're dealing with sepsis. And we wouldn't want to administer these intramuscularly because the absorption of the drugs is erratic. So it should be avoided, particularly in children who are critically unwell as well, because it's even more erratic in them. And of course, the oral route is not indicated with sepsis because they've got low intestinal perfusion and therefore low absorption. If we've got children who have evidence of sepsis, but they don't have any evidence of shock, then we can initiate these steps within 3 hours and we still get good outcomes. But with children who've got evidence of shock, so we're looking at, again, those cardiovascular sort of indicators in particular, then we need to get this initiated within 1 hour. And then we would give fluid resuscitation. So I'm going to talk about this a little bit more specifically in the next couple of slides. So 10 to 20 mils per kilo boluses, and then monitoring their response to that. And then once we've given them sufficient amount of fluid resuscitation, we'd then also include in inotrope support. So when does the clock start? So we're saying, we want to get this started within 1 hour. We want to get this started, within 3 hours. So when are we starting the clock? So if you want to start the poll for this, and we'll get people to vote, do we start that poll from when they present to ED or the GP? Do we present that poll from the first, do we start that timer from the first altered vital sign that we see? Or do we start it from the time that sepsis is recognised? Oh, looks like we haven't actually got this poll. So you are actually, you don't need to answer, but you can chuck it in the chat box if you like, what you think would be the appropriate time to start this timer, because, they say, start it from an hour. So what is an hour? When does that 1 hour start? So at the time sepsis is recognised seems to be the common theme. So yep, and that would be correct. So once we identify sepsis, so I suppose the thing to highlight here is that if we haven't identified sepsis, if there's been a delay in that recognition, then there's going to be quite a delay in our initiation of the treatment, isn't there? So it's really important that we do recognize it and respond to it early for that reason. Okay, so looking a little bit closer now on antibiotics. So we want to get these started within 1 hour of recognition of, that we've got sepsis. Antibiotics are crucial for the treatment of sepsis. So the timely prescription of them is one of our main goals to prevent mortality, especially for those children who have shock and that end organ dysfunction. If we don't have the signs of shock, then, as I said, within 3 hours also appears to be effective according to the research. Something to point out, if we're unable to get blood cultures or a lumbar puncture, we would not delay the start of antibiotics due to this reason. And we also want to keep in mind that we don't want to indiscriminately start antibiotics too. So again, coming back to that really good and thorough assessment so that we know that we're dealing with sepsis, because obviously giving everybody antibiotics because we want to prevent sepsis is not the right approach either. So local protocols will vary with what you want to commence in terms of antibiotics. So definitely make yourself familiar with your own environment, what you would start. But ceftriaxone 100 milligrams per kilo per day tends to be the common broad spectrum, which is generally agreed upon as the first line if you haven't got a pathogen yet identified. Other things that we look at is the severity of the child, like shock, how unwell they are, whether, we have any more information around what sort of bug they might have. Obviously, if we can obtain blood cultures, then we can grow something and have a bit more information to target the antibiotics. But something to be aware of with pediatrics in particular, we have specific bottles for pediatric patients. They require anywhere from 1 to 3 mils of blood, and they're only aerobic cultures. And so a lot of data shows that when you're using these smaller volumes of blood, because obviously we don't want to exsanguinate our pediatric patients by taking 10 mils off them all the time, it actually has a higher chance for it growing contaminant agents instead of the real non-contaminant pathogen of the infection. And so there's actually a correlation: the smaller volume of blood, the higher risk of growing a contaminant. So it's just something to be aware of again. And sometimes we never actually ever identify what that original pathogen is. So that's somewhere between 28 to 89% in the literature that's reported that no bug is actually ever identified. So this can be because we've decided to start antibiotics before we gave cultures. It could have been because of, those sampling issues with blood cultures. So there's a lot of different reasons why that may occur. And I've got a journal article that talks about antibiotics and sepsis with children, which, if you don't mind popping in the chat, Susie, if anyone wants to access. So now our next step, thinking about fluids. When we talk about fluids, we now have a range in a lot of protocols, which talks between 10 to 20 mils per kilo of fluid resuscitation. And this is because there was a rather large trial, which is called the FEAST trial, which is a randomized controlled trial of fluid bolus therapy in over 3,000 sub-Saharan children who had sepsis and impaired perfusion. And it basically showed that there could be some harm in giving fluid boluses. So in particular, if you don't have the ability to measure for fluid overload and you don't have a critical care environment to take them if they're requiring high levels of fluid. So it's definitely something that we have to take with a grain of salt, because the population of these children is very different to what we would find, in a developed country, and their definitions were a little bit different. So what it does highlight, though, is that we need to look at fluid therapy a lot closer and fluid bolus therapy a lot closer, and try and understand in children, what the right amount of fluid is that we should give them prior to starting inotropes. And thankfully, there's a few studies that are starting to look at that now. So we might see the amount of fluid that we give per kilo change over time for children. They might identify that we need to start inotropes earlier. But at the moment, we start with either 10 to 20 mil increments. So we're going to base that on what their blood pressure is, what their urine output has been, any comorbidities that they have, on whether we want to start with the 10 or the 20 mils. And then we want to continue to assess that. So have they had a response to that? Does their blood pressure come up? Do they start to produce urine? And then if we get to that point where we've given them a total of 40 mils per kilo, this is where we would need to, if we haven't already, spoken to a retrieval team, a pediatric retrieval team, so that they can then get access to a pediatric intensive care unit. And I've also got an article on this as well, which we can link in for you if you want to do some further reading on this. I do go into this in much more detail in our Surviving Sepsis course, because fluids are something that you could spend hours on in itself, particularly pediatric fluids. So if you're interested in learning a little bit more about that, I think there's a link at the end, so you can access that. So lastly, looking at inotropes. So as I said, if we've given, it depends again on your individual policy or procedure, but most policies will say greater than 40 mils per kilo. Some go up to 60 mils per kilo of fluid. We would then start to initiate inotrope support. So it's generally adrenaline or noradrenaline. And most of the time, you've been busy, you haven't inserted a central line, you might only have intraosseous access. So we're going to be diluting it quite a lot, and we're going to be administering it peripherally. Again, there'll be different local guidelines on how to do this, but generally it's prepared as 6 milligrams of adrenaline in 1 litre of normal saline. And we start that at 0.5 mil per kilo per hour, which equates to 0.05 mics per kilo per minute. And then we titrate that to effect. So the vasoactives, particularly adrenaline, is generally the first line of choice. And this is because we know that if children have shock and they have low blood pressure, we really need to address that because they've got myocardial dysfunction, which is coupled with varying degrees of vasoplegia. So those catecholamines can really help them. Other things that we need to think about if we're starting peripheral inotropes, we need to be accurately monitoring that blood pressure. So having that manual blood pressure cycling really regularly. And if you can, insert an arterial line so that we can have much more accurate blood pressure monitoring, moving towards a central line access as well. So we don't want to be doing peripheral adrenaline or noradrenaline for a prolonged period of time, because obviously that's going through, veins rather than a central access. So we want to have really good hemodynamic monitoring. They need to be on, ideally 5-lead ECG. And obviously, you need this child to be in a well-monitored environment like an intensive care unit. Okay, so if we have this poll?
No, sorry.
We don't.
I clearly vagued out with the polls.
No more polls. All right. Okay, well, I just had a question, which was basically, again, chuck it in the chat box if you like, if you want to weigh in on this. Do you think that parents should be able to call MET calls? I was really interested to see what the split would be on this, so, but doesn't matter. I'll survive.
Grace, as the answers are coming through, there's just been a couple of questions. So one is around, if you're outside of sort of a hospital environment, how many wet nappies would you advise parents to, sort of say is normal for a urine output? Okay.
So look, again, it depends on age. So obviously a newborn is going to have a lot more wet nappies than say like a 2-year-old. But if they've not had any wet nappies in a 12-hour period accompanied with decreased fluid intake and a illness, then I would have concern about that. And generally, I would encourage parents to have that child seen by a GP so that they could have their fluid status assessed and their, cardiovascular status assessed. If they've not had anything in one day, so we've had no urine output in one day, then that would be really, really concerning. So, like usually if it's, because some kids, particularly if they're aged 2, you can put them down at night and they'll wake up and they'll have one big wet nappy. So that's why sort of 12 hours. But again, that has to be coupled with all the other information. So we can't just only base it like, alone. Like, if I think about my own, 2-year-old who's now toilet training, we might have long periods of time in which she'll not, go to the toilet while we're sort of going through that process, but she's well, so there's no other signs that I have any concerns about her. So it is information that we need to take coupled with them being unwell not feeding. So, all of these bits of the puzzle have to fit together. So I think we sort of had a few yeses and nos.
Yes. The other question was around when you can't get IV access, about going to IM antibiotics, particularly for the meningococcal, and obviously in sort of areas where there isn't access to intraosseous or there isn't skilled people to put in an intraosseous.
Yeah, so I think there are some policies which do refer to intramuscular antibiotics as being something that you can do. I think the thing that we need to acknowledge there is that we're going to have variable response to that. So it's not going to be as definitive as us being able to give that intravenously or intraosseously. So I suppose our paramedics would be our people who we would need to respond and insert an IV or an IO. You might do the IM potentially if you know that that's going to be a long wait between those. It's definitely better than doing nothing for sure, but it's not going to be as beneficial because of that, distribution. Was there any other questions?
No, they were the main ones. The others I think I've addressed.
All right, awesome. So the reason why I asked this question around parents being able to call MET calls is because, we've been talking a lot about parental concern, and we highlighted that, from sentinel events in the ED, parents not feeling like they had a place to be able to, escalate their concerns was one of the big predictors of children having these events. And there are some different rules in different states. Susie and I were talking about Ryan's rule, which is in Queensland, and different states have got different processes for this. In the hospital where I work, parents are allowed to call MET calls, so they could just ring up the number and call a MET call for their child. So I think it's actually a really good thing. And we don't have a ridiculous amount of MET calls called by parents. They really do actually call them quite appropriately. And it's when they have been expressing concern and it's not been heard. So sometimes it just gets everybody together. It gets us to review that child again and talk about what's going on. And it can really help, escalate care appropriately. So we definitely should use parents as part of our assessment tool. So we talk about all this physiological stuff that we're doing, the history taking and the information that we get from the parents should be considered part of your assessment tool. Whenever I'm assessing a child, whether that's in an emergency department or in the ICU, I always consider the parents within my assessment. So I might even say things like, what do you think like they look like today compared to yesterday? And they might be like, oh yeah, actually they're so much better, they're less puffy. And for me, I've not looked after that child, perhaps, this is the first time I've seen them, and I might come in thinking, oh, they're really edematous, but the parents are saying, oh, actually they're improved on yesterday. So we really do need to include them as part of our assessment tool, and we should really heed what they're saying, particularly if they're saying something not right here and I'm really concerned. So we're just going to watch a video which highlights in particular this parental concern and sepsis.
For me to think there wasn't something right, there were a few flags that as a mother, you see in a child, when they just got a flu or a bug or a gastro bug or something. But everything we were doing, giving Cooper the pain relief, rubbing his leg, putting ice packs on it, they just weren't relieving anything. His temperature was still rising. It had hit 40.6 on our thermometer, and there was nothing that we could possibly do. And I said to my husband, this is something not right. This is not a gastroenteritis bug or a flu or a cold. I don't know. I think from a mother's perspective, I just knew that instinct that it wasn't something that we could treat at home. So the main trigger for me was his temperature wasn't coming down with any pain relief, and he was just very ill. The second time we needed to get Cooper to the hospital was his temperature was 40.6, and everything we were doing at home wasn't helping him. We needed to get him to medical aid pretty quickly. my husband went to ring GP Access, but by that time I sort of had him in the car, and I said, no, I'll meet you up at the hospital. We need to go. It was nothing we were doing at home. We couldn't bring his fever down. We couldn't relieve the pain. He was changing colour. He was just very sick young man. Yeah. On the way in the car, within about 6-7 minutes of driving, we didn't live very far from the hospital. We're only about 10 minutes away. I kept sort of watching Cooper at, my peripheral vision, and he ended up having a fit. He was convulsing. He was sort of regurgitating matter. So I actually pulled over off the road. And so I thought I couldn't do anything for him anymore in the car. I needed to get to hospital, which was just around the corner. So I cleared his airway out, sort of propped him back a little bit and held him with one hand and drove the car to the ambulance bay, or to the hospital, which was just around the corner. He was still breathing at that time, but he just wasn't with us. He was really quite unresponsive at that time. Very, very hot. I remember touching him and he was just hot. I drove around the corner. It was only just around the corner, and drove into the bus stop of the hospital. And at that time, Cooper did wake up and said to me, Mummy, am I dying? And I said, no, buddy, you're all right. We'll get you there. And I flew out of the car, went around. He's quite a large boy, and he was just, very unresponsive, very lethargic, quite hard to manoeuvre. I noticed that the security staff were coming out. I don't know if I was going to get in trouble or not, but they came out to assist. So one of the security guards actually got Cooper out for me and carried him, and then the security guard had got a wheelchair and put him in that. And they took him straight through to emergency while I just locked the car up and got my handbag. And the doctor just started hammering me with questions, had he been bitten by a snake? Do you believe I was a spider? Was there any poisons that were evident around the patient? He just had to go through that process of elimination. He ended up with about 10 or 12 nurses around him at that time, and then I had one or two with me. I don't know, I must have looked like I was in shock or something. And then they sat down and the doctor said, all right, we have to do this, otherwise he's not going to get through it. And they had to ask permission, to give him this. They said I think it was a broad range antibiotic, because they didn't know what was attacking him. He did have the little black dots come out on his leg, and the nurse and I think her jaw dropped as well when we saw that. She hadn't seen anything like that as well. And about 2 and a bit weeks, he was in hospital. He had test after test and blood test after blood test and MRIs, and so he was in there for around 2 and a bit weeks. I don't remember the exact time we were told what had happened to Cooper. I think it was around 2 to 3 days we were told that Cooper had sepsis.
So I love it how she went back and grabbed her handbag and locked the car. So I've skipped a bit ahead there. But look, that's a really great highlight of that parental concern, I think. And this is a video from the Clinical Excellence Commission and can be accessed on YouTube if you want to watch the full one. There's a little bit more there. So she actually had presented to ED once already and then had gone home, and then he obviously deteriorated, in which case she brought him back to the emergency department. So things that we can think about in terms of how we support parents to identify signs of sepsis. And if you're in a position to be able to provide education and guidance to parents and carers regarding recognizing the signs and symptoms of sepsis, or perhaps you're a carer of yourself, it's worthwhile knowing about these resources, or a parent yourself. The Queensland government has some great resources for parents and carers around paediatric sepsis, and they've just updated their paediatric sepsis checklist, which has a tear off. It will have a tear off the second sheet, which you can see, which is on the right hand side, different things that parents can check to see, you know, whether their child might be at risk of sepsis, and they can present. The other thing that we have to think about when we're communicating about sepsis as well is that we should all be using a common language to communicate with parents and carers. So we want to be using the term sepsis. We don't want to be using terms such as blood poisoning or septicemia. You want to have the same messaging going out to parents so that we can recognise these issues. And Sepsis Australia are really trying to encourage us to use this common language. We want to, again, encourage parents and carers to trust their gut, to trust their instinct, and give them a place, a safe environment for them to be able to, you know, advocate for their child and have options for escalating care, so that they, you know, because we can see that this is a really big predictor of sepsis in children, these parents saying this is different, there's something going on, I'm really concerned here. And we're nearly through, guys. I know we're a little bit over, so you can just hang in for a couple more slides. So I just wanted to talk about what the next steps were. Obviously, if we're out in a area where we don't have access to a critical care environment, we would have called for help super early, I hope. But if you're not sure what the flags are for a child to be managed in ICU, in a paediatric intensive care unit, they are things such as their cardiac output is still poor, despite the fact that we've given them 40 mils per kilo of fluid. We are giving them inotropes, so they need to be in a well-monitored environment. If they've got a persistently high venous lactate, so it's above 3 millimoles per litre, and it's not coming down despite us giving them fluids or what have you. If they've got any evidence of coagulopathy, so their INR, APTT or fibrinogen is off. If they've got neutropenia, or if we also identified that they've got a large pleural effusion. So these kids need to go to ICU. So in summary, thanks for hanging in there. Just some take-home points. Recognize that you've got a problem and call for expert help. And this probably goes across the board for all pediatric patients. You know, just have a chat to your friendly retrieval team, your friendly ICU team. We're always up for, you know, helping you problem solve. So just get on the phone and say, this is the kid I've got, this is how they're presenting, you know, what do I need to do? Make sure we're taking a full set of observations, a really thorough clinical assessment, because that's going to give us all the information that we need to take the next steps. Know the signs of sepsis. There are a few, but we've simplified it for you today. There's some common ones there that we can have as really high areas of red flags for us to go, yes, let's consider sepsis. Acknowledge parental concern. So if they're saying something is wrong, if their gut's telling them something is off, then we're going to trust that, and we're going to go back and take a look again, do your assessment again, A, B, C, D, E. What are you missing? What are you not seeing? Once we suspect sepsis, we're going to initiate the sepsis 6 as soon as possible, and we're going to just keep going back and reevaluating. What are these interventions doing? Are we seeing improvement? And if not, asking the question why. So thank you for joining us tonight. Hopefully you've gotten a lot out of this presentation, and hopefully it's answered more questions than it's raised. Often with paediatrics, we do end up asking more questions than we answer. But I think that there's quite a few things developing now and helping us to recognise the signs of sepsis and manage them in paediatrics. So it's really promising to see this develop.
Yeah, thanks everyone. And thanks to Grace for putting the presentation together and sharing all of your paediatric knowledge with us. Just as a reminder, you can access your CPD certificate through the course page, so that should be available tomorrow. You will need to do the evaluation first, and then the certificate will be there. You also do get the 10% off those courses that were at the start of the course, so you can get 10% off using the code sepsis821. So that's for our surviving sepsis course, the emergencies and general practice course, and our PACE, which is our pediatric clinical deterioration course. So jump on board if you're interested in those courses. But thank you, everyone. This was our first webinar for the year, so it's always nice to kick off the year on a really good quality webinar that we are grateful that you've all enjoyed. So we'll see you at the next one. Thanks, everyone.